So I'm going to get started. We have a couple people coming in. So, wow, thank you all for persevering to the end of the final, one of the final sessions today. I'm Laura Hummers. I am a rheumatologist and I co-direct Johns Hopkins Scleroderma Center. And I've been doing this work for the past little more than 20 years. So today we're going to talk about scleroderma and cancer. And we're going to start off with, well, why would we talk about scleroderma and cancer? So we'll get into why we want to think about this connection. So we're going to review a few things today. So we're going to look through the data that we have, or some of the data that we have that links scleroderma to cancer, and really focus on what that might mean for patients who are living with scleroderma and how we have to think about cancer and cancer screening. And does that need to be different in patients who have scleroderma compared to the general population? And then having for our patients who have scleroderma and cancer together, there are a number of challenges that we face in terms of the treatments for both the scleroderma and the cancer, and we'll walk through that a little bit. So I'm just going to talk about a case. So this is a case that actually prompted our group to start thinking about cancer specifically. And there are many case reports that are like this, where people had reported where kind of cancer and scleroderma started at the same time. And this is one of the first clues, maybe that there might be a connection, is that there were patients who would come and would have cancer and scleroderma happening kind of really close in time. And so that kind of raised eyebrows to say, could there possibly be a connection here, or is this just coincidental? So this case was a 43-year-old female smoker who had Raynaud's in 2006 and then developed swelling in her hands and feet. And when she was getting worked up for the symptoms she was having, it wasn't recognized that she was having scleroderma, but she had a chest x-ray, which was abnormal, and underwent evaluation for that, and ultimately had a biopsy, which showed cancer in her lung, which was a small cell cancer. And she was treated for cancer as expected. Again, this was without the knowledge that there might be scleroderma happening, and she received chemotherapy, radiation, and prophylactic brain radiation to prevent spread. But then within a year, her symptoms worsened in terms of not the cancer symptoms, but her other symptoms. And she developed Raynaud's phenomenon that worsened. Hands were more swollen, and then developed kind of diffuse thickening of the skin in lots of areas of the body. And it was actually worse in the port where she had radiation in her chest and upper back and around her shoulder. And then so she came to our center for evaluation. And the question was, what is happening? Is it that she really had scleroderma and developed lung cancer because there was an issue with her lungs and it was related to scleroderma? Was the skin tightness related to radiation? Or, could they be connected somehow? Could the reason that somebody has scleroderma be related to the reasons that somebody has cancer? And then importantly, I'm going to mention this antibody a few times. In this evaluation, she was found to have antibodies to a particular scleroderma specific autoantibody, which associates with diffuse skin disease called RNA polymerase III. And this is what that antibody looks like under the microscope. So when these two things happen close together in time, I think each of us would ask, well, did they really have scleroderma? And there's something about the scleroderma process that led cells to become cancerous. Did the treatment of the cancer somehow lead to the scleroderma? Did the cancer itself lead to the scleroderma? And then should the treatment of the cancer be different because of the presence of scleroderma? Should the treatment of the scleroderma be different because of the presence of cancer? And is there anything about this patient that may have predicted the presence of cancer? So these were the kind of questions that were asked. So at the same time we were thinking about these questions and others were thinking about these questions, epidemiologic data had come out. There's a cousin disease to scleroderma called myositis, where it had already been known that there was kind of a connection in some groups of patients, some subsets of patients, that maybe there was this high risk of cancer in certain groups. And the question is kind of, could the same thing be happening here? And people had started to look at epidemiologic studies to say, is there an increased risk of cancer among patients with scleroderma? And so if we have this many patients in the country with scleroderma and this many with systemic sclerosis, about 12% of those patients have cancer. And we know that malignancy accounts for 7 to 17% of all cancer deaths, but 17% of cancer deaths in the US in general are due to cancer. So it wasn't quite so clear based on kind of just this epidemiologic data if there was a connection. But when they did studies to take the risk of cancer compared to the general population amongst patients who had scleroderma, it did look like there was this increased risk, 1.5 to 2-fold increased risk of cancer, but it wasn't one cancer, it was like multiple kinds of cancer. So lung and breast were the most common seen in scleroderma patients. Those are also the most common cancers seen in the general population, but it was these cases of these simultaneous onset of cancers that made people think, maybe there's a connection in some patients. And then there were cases being reported in the medical literature as well that said, when you treat the cancer, the scleroderma seemed to be getting better, which was another tantalizing little piece of evidence to say, is there something more related here? Is the cancer part of what's driving the scleroderma? And if you get rid of the cancer, do things get better? So there were a couple of what's called meta-analysis. A meta-analysis is taking a bunch of studies and adding them together. So a bunch of people were publishing these studies and looking at rates of cancer in patients with scleroderma. And I'm going to show you 2 studies that put this all together. So this took 16 different studies with 7,000 patients in it. And again, it did look like when you took all this data together that the risk of cancer overall was somewhat higher compared to the general population. So this is a 1.75% risk. That means an increased risk of cancer above the general population. But this risk was increased for certain types of cancers, it looked like in this study. A few other cancers were also notable in this, liver and esophageal cancers. But this study was unable to look at other risk factors, right? So cancer is related to a lot of different things and exposures, and not just potentially related to scleroderma, but they couldn't look at smoking, these questions about immune suppressing medicines, what kind of scleroderma the patient had. So here's a different study that did a similar thing. This was 6 studies with a similar number of patients. They did look at gender and timing and the type of scleroderma that somebody has. And they still saw that there was an increased risk, about a 40% increase in risk compared to the general population. They saw some cancers that were common to the other study and some that were a little bit different. It seemed like maybe it was higher in men, but the men were more often smokers, and it wasn't clear if that was related to the smoking. But this study noted that the risk was highest or higher in the 12 months following a scleroderma diagnosis than more than 12 months. So again, this question came up again about these 2 things being connected in time together. And it was not clearly different by limited and diffuse scleroderma in this meta-analysis. And the lung cancer risk didn't seem to be related in this study to smoking or lung fibrosis. So if you look at these studies, was maybe this increased risk of blood and lung cancers, maybe liver esophageal cancers. There wasn't an excess breast cancer risk when it was looked at specifically, but that is still the most prevalent cancer that's seen. And maybe these things increase the risk. That one study suggested men, maybe older patients who are developing scleroderma, maybe the drug exposure that somebody's had because of their scleroderma. But this time piece was important, that risk seemed to be higher in the year after diagnosis. Most of these studies, I should mention, only looked at cancers that developed after scleroderma. So they didn't look at the ones before. So let's go back to this issue about timing, because I think, again, that was something that seems compelling, that these 2 things were potentially happening together. And could this shape how we screen patients for scleroderma, if we should be looking at the time of the scleroderma diagnosis? And does it shape how we treat newly developed scleroderma? So this is data that came out of our center. And at the time, we published this back in 2015, there was about 1,000 patients, and about 16% of those patients had cancer. And 22% of them, we called it cancer-associated scleroderma. Why? Because the 2 things seem to happen together. So this on this graph here, this bottom of the graph here is time in years. And this is the interval between cancer and scleroderma. So these are cancers that happened before scleroderma was diagnosed. This 0 mark here is the exact time that it means there was 0 difference between the time their cancer was diagnosed and their scleroderma was diagnosed, i.e. they were diagnosed at the exact same time. And these are ones that happened after. And if we looked at this whole group, these 168 patients who had cancer, there seemed to be a peak of cancer in terms of this timing issue between when scleroderma happened and when the cancer was diagnosed. And then we said, well, is this clustering the same for everybody? These two things occurring together in time, is that the same for everybody who has scleroderma in our population? And so we looked at the timing of cancer and the timing of scleroderma, and we separated patients by the antibody that they made. So these patients didn't have an identifiable scleroderma-related antibody. These patients made that RNA polymerase 3. These patients made that, it's called anti-topo or SCL70 antibody. And this is the anti-centromere group. And this is, again, just looking at the interval between the time that cancer was diagnosed and the time that scleroderma was diagnosed, and says, so how close did these two things happen together in these different antibody subsets of patients? So this is a group of patients who had both, right? And so the important thing here is this group, this RNA polymerase 3, like when they had cancer, they all had cancer and scleroderma happened at the same time. And it was strikingly different than the other subsets of patients, right? These SCL70 patients, those two things were separated by 10 years or more, same with the centromere group. Maybe this group was kind of closer to the 0 line, but this was distinctly different. So RNA3 polymerase positive seem to have a unique high risk of cancer around the time that scleroderma emerges. And then subsequent to the study that we did looking at this, several other groups kind of found the same association with RNA polymerase 3 in cancer. Okay, so I'm going to walk through this slide. So then the question became, is this kind of an epiphenomenon? Are they actually mechanistically related? Meaning, is there something about these two things together? And the hypothesis was at the time that maybe the cancer is driving the production of the autoimmune disease. And so to test that, we took our patients who had cancer in different antibodies, but specifically this is about the RNA polymerase 3 patients, and took their cancer specimens. So we requested those and looked at the slides, and then looked at this RNA polymerase expression in their tumors. So when we did that, the patients who had cancer and scleroderma, who made this particular, we're being invaded, this particular antibody had RNA polymerase 3 expression in their tumors that was abnormal and mutated. So the genes that encode these proteins were mutated in the tumors of patients with this antibody. And it was specific to the patients who made this antibody and had the tumors. So we only saw that staining in the patients who made that antibody. So this suggests, and the antibodies, interestingly, recognized both this mutated protein and the regular protein. So this was a little bit of a smoking gun to say that it probably looks like the immune response that is being generated that we associate with scleroderma, the presence of this RNA polymerase 3 antibody, which is very specific to scleroderma, is probably coming about because the patient is trying to clear a cancer. And then, when we looked at other antibodies and other things, it wasn't seen. So what does that mean? So what we do know is that our immune systems all the time are trying to recognize and fight off cancer, right? That's part of the surveillance job of our immune system, is to recognize something that is foreign or abnormal and kill it, right? And we are probably doing this shockingly frequently, right? That's these mutated proteins develop, your body recognizes it and says, hey, we don't like this, let's get rid of this, and it eliminates it. And we are probably doing this all the time, and most of the time this works very efficiently. So our immune system sees this abnormal cells and said, hey, don't like this, let's get rid of it. So what could happen in that situation? Well, you could get rid of it. So you eliminate this cancerous cell, it goes away, you move on, nothing else happens. It could not work well, or the tumor gets smarter than the immune system or progresses faster or something, and you can't control it. And, patients get cancer in that. But it's possible that you could go through this process and get your immune system primed to kill these cancer cells and then develop a autoimmune disease along with it. So I'm trying to fight this cancer cells, but whoops, I start recognizing normal cells or normal proteins in the process. And then that's allowed to go. And then somebody could get cancer at the same time. And then we see this, right? These are the patients who come to us in that group that we talked about who have scleroderma and cancer together. And then you could develop scleroderma, but maybe you got rid of the cancer. So your immune system effectively killed that cell, but the consequence of it is that you are still now making antibody that is now unfortunately recognizing self. And that's a situation where the autoimmune disease could present, but you never see the cancer, right? And these are all possibilities. So the timing of the cancer diagnosis and scleroderma onset really was the key here. And if cancer could be triggered by a trigger for scleroderma, particularly in these distinct autoantibody subsets, what does that mean in terms of should we screen new patients with this kind of scleroderma for cancer? Should we use antibodies alone in combination as ways to risk stratify somebody to say, oh, what is your risk for cancer versus somebody else? Because just so you know, and I'll say this multiple times, the vast majority of our patients do not have cancer. So this is clearly not an explanation necessarily for everybody who has scleroderma. So we need to learn about who those risk groups are. And if we treat the cancer in the case of somebody who has cancer and scleroderma together, does that have implications on what's going to happen to the scleroderma? Okay, so we wanted to know who is at risk, when, and for what. And so we did a study with our scleroderma database, and we compared it to what's called the ScM registry. So this is a large nationwide cancer registry to look at the epidemiology of cancer. And then we wanted to know, does the cancer risk overall in scleroderma, or is it for specific subsets, or is it specific cancer sites? So we looked at based on antibody, the kind of scleroderma somebody has, and again, timing. So at this point, we had a larger number of patients and a somewhat larger number of patients with scleroderma and cancer. And so when looking at the risk of cancer within 3 years of scleroderma onset compared to the general population, we saw that patients both who had diffuse scleroderma and this RNA polymerase III antibody had an increased risk of cancer. And then if you take this RNA polymerase III group and you subdivide it by the type of skin disease that they have and the specific cancers, there were a few cancers that popped out as being significantly higher risk in specific subsets of patients. Again, those with RNA polymerase III who had these different kind of skin subsets, but it was different if you had RNA polymerase III in diffuse skin or limited skin. And just to not panic people, when you see, a 43 times increased risk of tongue cancer, yes, that's a 43 times increased risk. The overall risk of developing tongue cancer is incredibly low in the general population, right? So you could have a substantially increased risk of cancer compared to the general population, but you're comparing that to a teeny tiny little number. So when you multiply it, it's still pretty low. So it's not like all of our patients are running around with tongue cancer. This is still in very infrequent cancer. So don't panic when you see some of these numbers in terms of the increase in risk or fold increase in risk. So we learned from this that maybe antibody type and skin type may define subgroups at higher or even lower risk for cancer. And actually this lower risk for cancer thing was a complete surprise when we did this study. So this is a complicated slide. I'm not going to walk you through all of it, but let me point out a few things. This is looking at cancer, our patients, sorry, compared to the general population risk over time. And this is just several statistical ways to kind of look at this. But I want to point you to the bottom here, which looks at the risk of cancer over time in the general population, which is this red line, which is really hard to see here in the all group. So this is everybody that we looked at because it's somewhat largely overlapping with the general population. So that kind of goes along with these studies that looked at all patients with scleroderma and said the increased risk of cancer is a little bit higher, but it's not that dramatic. And that's what we see here, that if you take all of our patients, the risk doesn't seem, significantly higher than in this general population, which is this red line here. But here's the RNA polymerase III. So this is the red line is the risk in the general population. And this is our patients looking at their risk and how over time from the onset of disease, their risk increases. So they are clearly different than the general population, the people who make this RNA polymerase III antibody. It was about the same in people who made SCL70. It kind of falls right along with this line. You could argue maybe at the end here was a little bit higher. It was a little bit higher, interestingly, in these patients who didn't make one of these 3 antibodies. And we saw that in the other study I showed you, that maybe there was a group there, and we won't talk about that too much. Here was the surprise. So this is the patients who make centromere antibody, one of the 3 most common autoantibodies in scleroderma. Here's the risk in the general population. Centromere falls under it like the whole way. So not only did we see this subgroup of patients where the risk of cancer seemed to be higher, we found another group of patients where the risk of cancer seemed to be lower, which is probably a really good explanation for why, when you look overall, it just doesn't look that dramatic, because there are some people who seem to be higher and some people who seem to be lower. So what did we learn here? We again learned about this temporal relationship between cancer and scleroderma, particularly in patients with RNA polymerase III. We found compelling biologic data to suggest that cancer is related to the production of autoantibodies and probably the autoimmune disease. Centromere antibody is strikingly decreased in cancer risk, which may suggest that patients who make that antibody response maybe have actually a better response against tumor, right? Maybe there's something about making an antibody to that particular protein that's particularly effective for cancer. Maybe still spills over and causes an autoimmune disease, but maybe it's actually that immune response is somewhat better at killing cancer cells. And that the type of antibody you have and what kind of scleroderma you have may inform us about risk and type of cancer in our scleroderma patients. So just to take a step back, because I've talked about this antibody multiple times, patients who make this RNA polymerase III antibody have a very kind of unique clinical presentation of scleroderma. So it's about 5 to 18% of patients have this antibody who have scleroderma. It depends a little bit on what country you live in. So in the US, we're closer to this 18 to 20% of our scleroderma patients have this antibody called RNA polymerase III. In other countries like France, for whatever reason, they don't see this antibody as much. So it depends on where in the world you live. But as a group, patients who have this antibody are unique in that they have the most aggressive skin disease. So just like that patient I presented had that kind of rapid evolution of the tightness of their skin, that's pretty characteristic of people who have this type of scleroderma. They seem to be at highest risk for scleroderma kidney disease, which is uniquely tied to this population of patients. So the overall risk in a scleroderma population is 3 to 5% of having a scleroderma kidney crisis. People who make this antibody, it's probably 25 to 30. Interestingly, these patients have a lower risk of having significant interstitial lung disease, but there is this increased risk in cancer. So this, even if you don't know the antibody, this is a subset of patients that's almost recognizable by the way they present. Okay, so now you're all thinking, what does this mean for me? And what should I do about trying to understand my risk for cancer, right? That's what we want to find out. So unfortunately, after the last 10 years of kind of making some of these discoveries about cancer and scleroderma across the world, there's really little data on the optimal way to screen for cancer and scleroderma. But we do think that doing kind of age, sex, and risk factor-based cancer screening is important. And that's probably true in the general population, right? If you have a family history of colon cancer, we screen you differently than if you don't have a family history of colon cancer. And the question is, should we take patients who we think are high risk and use more aggressive screening strategies for those patients? So if I see a new patient come in with RNA polymerase III antibodies, should we do something above and beyond the general, like you should get your pap smear mammogram kind of screening? So this is the way we've approached this. So we think about kind of three things. So if we have a newly diagnosed scleroderma patient, they get a full exam at diagnosis, right? So they have lymph nodes in their neck and their armpits. They get a, thyroid, we look at their skin. Is there anything abnormal there? We tend to look in their oral cavity, just again, because some of those head and neck cancers that was seen. As part of the evaluation for new onset scleroderma, everybody should have a CT scan of their chest. Like, we just think that's part of the evaluation for new diagnosis scleroderma. So this is not because of cancer screening necessarily, but everybody should have this. You may or may not know they've lowered the age for when everybody is recommended to get a colonoscopy from 50 to 45. So if you come to us and you're over the age of 45 and you haven't had a colonoscopy yet, we're going to say you should absolutely get a colonoscopy. The guidelines now say over the age of 75, you can stop doing colonoscopies. But if I had a new onset RNA polymerase III patient come to me who was 75, and they said, oh, I don't have to get colonoscopies anymore, but they were in that risk group, like, I would probably think of getting one, even though that is not the kind of current recommendation. And if they can't do a colonoscopy for whatever reason, we should do like a milder test or stool DNA to do something to look for colon cancer. Again, because this is general population screening recommendations. And then we talk to people about smoking cessation and sunscreen, right? Because that's important in the general population. So this is kind of new patient. Let's just kind of think normally about how we would proceed with scleroderma, with the exception of that we would get this CAT scan to assess their scleroderma, not necessarily for cancer screening. Now let's go into gender specific things. So women should be getting mammograms at diagnosis and annually if they're over the age of 40. Pap smears are recommended again every 3 years from ages 21 to 65. We might think about that again a little bit differently depending on what somebody's risk is and if they had new onset scleroderma over the age of 65. We would probably do it once if somebody presents with new onset scleroderma over the age of 65. Updated gynecologic and pelvic exam at diagnosis. If you have a particular set of risk factors where we think the risk of ovarian cancer might be increased because it's in the family or strong family history of breast or ovarian cancer, we might say, let's do a transvaginal ultrasound and a blood tumor marker for that cancer in selected patients, but probably not in everybody. Who is that? That's if you have a first-degree relative with ovarian cancer, known BRCA positivity, or a history of early breast cancer. And then men, by the way, do you see this? This is all the stuff women have to do. Here's the stuff men have to do. Rectal exam and PSA for prostate cancer. And if you're under the age of 40, the recommendation is to get a testicular exam. Again, this is general population cancer screening recommendations. So then let's think about kind of specific groups of patients based on their risk factors. So patients who are smokers, there is already a recommendation in the general population to get what's called a low dose CT scan. If you've had a significant smoking history, this is a general population recommendation. There are some of our patients who have risk factor for liver cancer because some of our patients have also happen to have another autoimmune disease called primary biliary cholangitis or primary biliary cirrhosis. And there's already a recommendation in patients who have that diagnosis to get liver ultrasound and a blood tumor marker to look for liver cancer. But that's only in this group who also happens to have this other diagnosis. Esophageal cancer may be of concern or more concern in scleroderma patients because the amount of reflux our patients have. So we don't screen everybody necessarily with endoscopy, but if somebody has really bad uncontrolled reflux and or they have swallowing troubles, that may be a group of patients we might want to consider endoscopy on. And again, if you have upper, we call it oropharyngeal, so like getting food from mouth to the upper throat, if that swallowing difficulty is not explained by something else, then maybe we would say an ENT exam to make sure we're not missing something in the back of the throat, because that's not a typical swallowing trouble necessarily for scleroderma. And then patients with high sun exposure, or we see anything on exam as a rheumatologist, it doesn't take much for me to say, I don't know what that is. I'm not a dermatologist. Maybe you should have a dermatologist to get a full skin exam. And then what about kind of the scleroderma related things? So we already talked about our RNA polymerase III antibody positive patients. If somebody's developed newly diagnosed scleroderma over the age of 60, because our studies also suggested the age of onset of scleroderma might be a risk factor. If somebody has aggressive, atypical, or treatment unresponsive disease, sometimes we think, oh, like, is there something else driving this disease that we're not controlling? If somebody has profound weight loss, may make you think of cancer, or if somebody has a personal or striking family history of cancer, that may influence how we decide to screen somebody. So the question is, if you have just this, RNA pol 3 or new onset scleroderma over the age of 60, or something about your scleroderma that's kind of a red flag, should we do additional screening things like a chest, abdomen, and pelvis CAT scan, an ENT exam? And the answer is we don't know yet because people have not studied this. But I will tell you what we are doing in our center is we have a research protocol to take patients who have new onset RNA polymerase III positive scleroderma. And as part of research, we are getting a whole body PET CT, a breast MRI in women, and circulating tumor markers to answer the question, will we pick up more scleroderma cases, more cancer cases in our scleroderma patients if we do this enhanced screening? So the answer is we don't know yet. So we still have to kind of go based on these traditional risk factors, somebody's personal risk factors in terms of family history. If somebody has some of these kind of red flag symptoms, right? Their disease is really aggressive, they're losing weight, we're not sure why. Clinically, you could probably argue to do things like PET scans at that in that situation. But we are trying to understand if doing something like this will really help us. Now, I'm going to switch gears a little bit because there are a few somewhat unique situations for patients who have both scleroderma and cancer together in terms of the management of their cancer. And these are really tricky situations that need, I would say, a really collaborative approach between oncology teams, radiation oncology teams, and rheumatology to figure out the best strategy to address some of these issues. So the first comes around the need for radiation therapy. So there has been a concern about exaggerated fibrosis. We all know the word fibrosis. That means kind of excess scar tissue, which is already an issue in patients with scleroderma. Radiation by itself can cause an increase in scar tissue. So should we give radiation to patients who already seem to be predisposed to scar tissue formation? So that's one question. And I can tell you, we see a lot of radiation oncologists who just say, you've got scleroderma, no radiation. Even if that's the known optimal way to treat somebody's cancer, they will say just flat out, no, you can't have it. And the other unique situation that comes out is that this new group of cancer treatments called immune checkpoint inhibitors. So this is basically revolutionized cancer treatment. These immune checkpoint inhibitors, what do? They release the brake from the immune system. They take a brake off the immune system, because I said the immune system is helping to fight off little cancer cells all the time. So your immune system is kind of primed and ready to kill cancer cells. Immune checkpoint inhibitors remove one of those brakes on the immune system to let it run a little bit more aggressively, which is really helpful if you're trying to kill a cancer. Says, okay, we'll just move the brakes a little bit. We'll let your immune system go after these cancer cells. And it has been incredibly effective for a whole number of cancers. What's the side effects of immune checkpoint inhibitors? Autoimmune disease. So we remove the brake from the immune system. Your immune system's allowed to run a little bit more unchecked. And there's both concern about exacerbation of an existing autoimmune disease, and there's been a ton of development of de novo, of new autoimmune disease in the context of taking one of these immune checkpoint inhibitors. So these are two really particular concerns in people who have an underlying autoimmune disease like scleroderma that causes fibrosis. And again, it's an autoimmune disease, so these immune checkpoint inhibitors are a potential concern. But sometimes these are the best treatments available to treat somebody's cancer. So we have to balance the most effective treatment for somebody's cancer, and then what effect is that can have on somebody's scleroderma. So we went back, and one of the ones that comes up pretty much regularly for us is the issue with breast cancer and radiation. So in patients who have kind of early stage breast cancer, patients are often offered two treatments. They could have a mastectomy, or they could have lumpectomy and radiation. And so this comes up all the time. So we went back and looked at our patients, both at our site and in University of Pittsburgh, who has a large scleroderma registry as well. And we looked back at our patients who had breast cancer and were treated with radiation and had scleroderma. But this is fairly small numbers of patients, probably biased by the fact that many radiation oncologists will not offer radiation to patients who have scleroderma. So these numbers are somewhat small, and we are looking back retrospectively. So it's not like we said, oh, we should look, we're going to decide to study this and look and see what happens. We went back and looked at this. And about 50% of the patients develop localized skin thickening. So in the radiation field, so where patients are getting radiated, there was localized skin thickening. And interestingly, that wasn't different between scleroderma type, whether they had diffuse skin disease or limited skin disease, what antibody they made, or how long that they had scleroderma. But importantly, we didn't see any flares of scleroderma, either in their skin or their lung, so their skin more generally outside of the radiation field, or in their lung. Now, breast radiation, they try to target it, so it really tries to avoid the lung as much as possible. And so there's not a ton of radiation to the lung in breast cancer radiation, but there is a little bit. And we didn't see any flares of scleroderma with regard to their lung function over time or their skin more generally. And then we also looked at our patients, because the other place that often gets treated with radiation is head and neck cancer. So this is even a smaller number because the cancer is less frequent. But this is a case where radiation is, really standard in the treatment of most head and neck cancers. So we saw lots of local skin thickening in the port of radiation, reduced range of motion in the neck. So if you get head and neck cancer, obviously this is where you're getting the skin changes. And a few patients required feeding tube because of the swallowing issues that come along with head and neck radiation. None of them required breathing support because, again, you're targeting breathing structures there. But again, we saw no progression of the lung disease, and one patient had skin progression, but they were in the first year of their treatment, and that's a time when the skin might be progressing anyway. So this is these things, by the way, happen in patients without scleroderma. It's really hard to compare our rates in this kind of selected population to kind of all comers who don't have scleroderma with neck and radiation, but these are pretty common in patients who get radiation without scleroderma. There are some preventative strategies that can be done with this, and we think that maybe using a drug called IVIG in this scenario to help with some of these symptoms may be reasonable because this drug is not immune suppressing and doesn't associate with an increased risk of cancer. So it's something that could be given to this kind of unique population. But this is kind of both of these scenarios are kind of a risk benefit ratio, right? So we'll say, okay, if the localized skin reaction to the radiation is slightly higher, but we don't see anything else happening to the scleroderma, but this is by far the best option to treat your cancer, and head and neck cancers are serious cancers to treat, then maybe we still favor giving radiation in that situation. We often do, I will say. Breast cancer, that's kind of more of a personal decision, right? So we say the local reaction to the skin might be different in a scleroderma patient compared to the general population. But in that situation, most patients have a risk, have an option of, do I want to do lumpectomy and radiation, or do I want to do mastectomy? So I think, again, this is a collaborative decision-making process that should involve rheumatologists, helping the oncologist understand this, the radiation oncologist understand this, the patient, and then the oncology team to say, okay, we may not be able to exactly quantitate what these risks are, but here's what we know based on this limited information. Let's group decision make here about what we think the best option is. Okay, let's switch gears now to immune checkpoint inhibitors. So again, new kids on the block in the cancer world. Many drugs now with many different types of cancers that are being treated with these immune checkpoint inhibitors. So we looked back at 8 patients who were in our center who had been given immune checkpoint inhibitors as part of their cancer treatment, and they also had scleroderma. So we saw 3 patients who had 5, they call these IRAEs, immune-related adverse events, which is the usual stuff that we see in the general population who get these drugs. They can get inflammation in their colon, inflammation in their mucous membranes, their mouth, their skin, and their lungs, sometimes their kidneys. So we saw those. And again, this is symptoms that are reasonably common in the general population who gets immune checkpoint inhibitors. What we didn't see was flares of skin, lung, muscles, or joints in scleroderma in the limited population. But we saw one patient who had progression in their skin, a renal crisis, which was tricky, right? Because this was a brand new, not uncommonly, right? This is the group of patients who are often getting treated for cancer, new diffuse scleroderma that was undiagnosed at the time they were given the immune checkpoint inhibitor. And, again, RNA polymerase 3 patients are high risk for progressive skin and renal crisis. And steroids actually increase the risk for renal crisis. And this person had to get steroids because of this kidney inflammation that they got because of the immune checkpoint inhibitor. So it's hard to say if any of this was really related to the immune checkpoint inhibitor or not. So this is a small series of patients. So again, now how do we counsel people when it comes to radiation and immune checkpoint inhibitors? So radiation, localized skin thickening may be seen, but no compelling data to suggest that the disease overall gets worse. Immune checkpoint inhibitors, we didn't see any data, at least in limited patients, to suggest flare. The one diffuse patient is really hard to say. The risks in early diffuse may require, further study. But if patients are getting these treatments, particularly if they have ILD, particularly if they're getting radiation or immune checkpoint inhibitor, we really want to watch their lungs closely because both radiation and the immune checkpoint inhibitors are associated with issues in the lung. So we do probably need to watch these things more closely in patients who are getting these treatments. But I would conclude to say scleroderma is not an absolute contraindication to either radiation therapy or immune checkpoint inhibitor therapy, but it is really important that the whole group think very carefully through the use of these treatments in patients who have scleroderma. So I'm going to summarize here. We don't have time to talk about all the possible things that may be connected. There are a whole bunch of other things we need to think about the drugs we use to treat scleroderma and their risk for cancer, and then the cancer drugs and the effects that might have on scleroderma. Those are really individual, I would say, kind of issues. We need to think about specific drugs. We need to think about specific risks with regard to the scleroderma side, but I'm happy to talk about those in the questions. But subsets, just like everything else in scleroderma. We think fairly narrow subsets of patients with scleroderma have an increased risk of cancer, and this is particularly around the time of scleroderma developing. Age, sex, and risk factor-based cancer screening is very important. We will hopefully know soon whether doing enhanced cancer screening in patients with this kind of scleroderma makes sense. And radiation and cancer immunotherapy are not absolutely contraindicated in scleroderma, but this is a careful multidisciplinary medical decision-making that's necessary to treat some of these, to address some of these kind of nuanced treatment decisions, mostly about the cancer. So I'm going to stop there. We have a bit of time to take questions and happy to do so. Thanks. All right, questions? Oh, quiet group. That means you didn't understand anything I said. I hope that's not true. In the back. Yeah, so the question is, like, what do we do with people who are kind of outside the traditional screening recommendations? So I actually just had this happen in my clinic last week, a couple of weeks ago, with a 26-year-old who was newly diagnosed RNA polymerase III positive scleroderma. And she was really interested in enrolling in our additional screening protocol that has breast MRI and PET scan. And I said, well, wait a minute, like, we don't even recommend a mammogram in this case. Like, should we be doing breast MRI? Anyway, we elected to screen her for breast cancer, and she enrolled in our protocol. So I think that's an individual decision still. But the answer is we don't really know, but I do think of doing some additional things that we, outside of the ages we normally think, like older patients, getting pap smears and colonoscopies. I think we could think about it the other way too, that maybe we should get, a mammogram in a younger patient. I would definitely think about it if there's a family history of certain cancers in the family. I would probably think about it. Insurance is a whole other issue that we're not going to talk about because it makes my blood boil, but to talk about insurance, but trying to get some of these testing done outside of kind of the normally screened population, trying to get PET scans done, trying to get these things clinically is a bit of a challenge. So, but I would think about it. There's another question somewhere here. Oh, here.
Lung cancer, and I guess any one of the types of scleroderma, because just from knowing friends in the community, people that have had scleroderma for a while, I've heard of some people passing through cancer. That correlation, or is there?
Yeah, so lung cancer was kind of up and down in some of the analyses that were done in terms of the risk. And I would say lung cancer in particular is a little bit more complicated, both in terms of the possible connections between scleroderma and cancer, and the testing that we do to screen for lung disease from the scleroderma, right? So I said every patient with newly diagnosed scleroderma should absolutely get a CT scan of their chest because we're trying to look for lung disease as part of their scleroderma. So we definitely want to do that. And I think smokers are a no-brainer. So if you reach a certain threshold of how much you smoked in your life, there is already a recommendation for repeat low-dose CT scans of the chest. And those patients absolutely should be getting those done. And for people who have interstitial lung disease, known interstitial lung disease, not just at the beginning, we do periodically follow their CAT scans. So I think a lot of those things we are doing. Now, some of these connections, there's probably kind of another connection that we think about sometimes, which is patients who have scar tissue in their lung. There's this concept that maybe the scar tissue, in the process of like creating scar tissue, maybe that proliferative kind of process could lead to a cancer. We certainly see cases where we think that might be true. So patients who have established fibrosis in their lung for a long time, have an area in their CT scan where the fibrosis looks a little more dense, and we go and look at it, and it turns out to be this adenocarcinoma, which is a non-smoking related cancer of the lung. Those things usually get picked up because those patients have fibrosis and we're monitoring their lungs anyway. And then the only other thing I'll mention is that our study suggested that patients who make RNA polymerase III antibodies who happen to have limited skin disease, which is a distinctly unusual subset of patients, that particular subset of patients seem to have an increased risk of lung cancer. And maybe I would look at those patients. I would think about those patients a little bit differently. I mean, the good news is we're looking at the lung pretty regularly a lot of the time. So, but that smoking population is unique, and we do want to make sure those patients are getting the CT scans they should be getting. Yeah, back there, purple. Hi.
So I have not had cancer yet, thankfully, but I've had multiple what are ultimately pre-cancerous tumors. So what is, as far as a risk factor of having scleroderma, I have multiple cancers.
So the answer is it depends, of course. When we're talking about individual patients, what type of precancerous tumors are we talking about? What kind of scleroderma you have? How long you've been having it? Have scleroderma, right? So, most of the data we showed suggests that this critical time is around cancer diagnosis. And we, didn't see much happening when these two are separated. And that may just be the normal cancer that occurs in the population. So in terms of the ones that are related to the scleroderma, that period is kind of around the time of cancer diagnosis. So we do think about that timing issue. So I think it depends on what type of precancerous things we're talking about, the kind of scleroderma that you have, what the antibody you make is, how long you've had scleroderma. So I think that's complicated. But there's usually a recommended follow-up if somebody has precancerous lesion X, like in the esophagus, a precancerous polyp in the colon, in the skin, like there's always a kind of a recommended, you need more aggressive kind of follow-up for this, and that should definitely be done. So, yeah. Oh, thank you. Thank you for asking that question. So that's another area we couldn't go over because that could be a whole other talk by itself. The answer is yes. So just like the immune checkpoint inhibitors, removing the brakes from the immune system could lead to an autoimmune disease. Us treating an autoimmune disease with immune suppressing medicines to suppress the immune system from fighting self could also potentially suppress the immune system from fighting tumor, right? So we always worry about cancer risk when it comes to some of our immune suppressing medicines. How much medication you get, what type of specific medication you get, those risks may be variable. But I will tell you that take CellCept, for example. CellCept is a very commonly prescribed medicine in the scleroderma community. It's used often to treat kind of skin and lung disease in scleroderma. That drug has been shown to be associated with increased risk of non-melanoma skin cancer. So these are the kind of sun-related skin cancers. The tricky thing about that data is that most of it comes from transplant populations where CellCept gets used pretty regularly. And those patients are also usually taking multiple other immune suppressing medicines. So the question is how much of it is directly tied to the CellCept or not, but what do I do in that situation? For example, my CellCept treated patients, besides, looking for skin lesions, I make sure that my patients who are on CellCept are getting kind of a full annual skin exam by a dermatologist to make sure we're not missing something. Cytoxin, which is a drug we don't use that much anymore, had very specific risks in terms of the dose of Cytoxin that was given and when the risk of cancer goes up depending on how much exposure you've had to the drug. And it has a particular increased risk in bladder cancer. So we'll counsel patients who have ever received that medication that we might be getting additional kind of urine tests and things like that. So it's a little dependent on the drug and the situation, but we do have to think about that in our immune suppression. Yeah.
How about the